in quotation marks. Okay, so that was my soapbox about what disparities are, my perspective, and how I'm looking at this information. So we started by looking at differences in access to dental care by race and ethnicity. And if you're thinking about what are the contributors to access, we're all used to looking at individual characteristics. I, as an individual, what's my age, what's my gender, what's my work status, what's my insurance coverage, everything that has to do with me as an individual, what I have that allows me to use services. But also, we always have to think about individuals within a greater context, right? We are all living, working in a greater context. And that context can be looked at from various perspectives, or can be several contexts, I should say, that we're looking at. One of the contexts is the healthcare delivery system, right? Who is providing services? How are services organized? And how does that organization play into the my ability to access services? Then there are other factors. There are the political factors, for example. What are the dental benefits that are available in the community or in the state, for example? What are the mandates that are there any mandates for dental benefit to be included in insurance coverage? That makes a difference in my ability to access dental care. What about Medi-Cal coverage, for example, of dental benefits? Medi-Cal dropped dental benefits in 2009 for adults. What kind of impact does that have on the population beyond the control of the individual at the contextual level? And then there are environmental factors, for example, water fluoridation. That impacts my oral health status, which in turn could impact my utilization of services. Social factors, what are the values around oral health care? What are the practices of the population around, for example, children receiving oral health at a very early age? Those are more of the social factors as well. Okay, so what we are going to talk about specifically is the dental delivery system. And how does that impact access to care? Well, what about the dental delivery system? How are we going to look at that? That's going to be a big question. It's sort of occupied a lot of people's time and minds. And we're going to look at the supply, particularly because it is one of the most common, perhaps easiest ways of looking at the ability of the individual to access services. And it is an important predictor of access to oral health care. Adequacy of the supply has obviously been a major source of concern. There's a lot of research around the workforce issues. Are we training sufficient number of dentists and other providers to make sure that everybody has access? And we want to make sure that the distribution of the dentists and dental providers is even, and there's no uneven supply in different areas. We also want to make sure that supply is, and then we have to figure out what is the best way of measuring supply. I'm going to talk about this a little bit later, but one of the common ways of looking at supply is looking at how many dentists there are in a given area, given the size of the population. So we sort of try to get a better understanding of how much workforce is needed for the population. Here we're looking at the supply of dentists in California. This is 2008 licensure data. And when you look at this, you see, okay, there are definitely supply, could be a major concern for this reason. There are some counties in the state where they have very, very few dentists given the population the size of the population. For example, in Inyo County, there are a total of 2 dentists. Look at the size of the county, and in terms of the population, you can see that it's got one of the lowest ratios in terms of a dentist to population. Another county, look, Northern California, dominated by several counties that have very few dentists. Alpine, no dentists. It is also a relatively mountainous area, you know, it's not very highly populated, but if you live there, you know you have to travel a very long way. So you can get certain useful information when you look at supply this way, right? You know at least there are no providers in some areas, or there are very few providers in some areas. You know something about the underlying population, so you can come to some conclusions. It's not necessarily highly informative, but it gives you very good basic information about supply in terms of distribution of dentists. And then if you looked more carefully at some of the other specific areas, so you could see the rural areas in the previous slide, a lot of shortages potentially. You look at the more urban or largest areas, counties in the state in this case, and look at the difference between San Francisco, for example, and Los Angeles County. Los Angeles County, huge population, 3.3 dentists per 5,000. San Francisco, 6.1 dentists per 5,000. There are either a lot of clean teeth there or lots of dental problems. I don't have the answer. I don't know. But it's certainly interesting. What is the appropriate level, again, is not really, you can't tell. Is this appropriate or not? What is the best ratio to have? Still can't tell. We don't know, at this point, we really don't know much about the population and the level of need, their utilization patterns, or any of that information. So what we want to do is sort of take a step forward and actually try to link supply to access. So let's start looking a little bit more carefully at what else, how are we going to do that? So this is based on Anderson's model of access. It should be familiar to a lot of people, where if you're looking at the bottom of this page, you're looking at an indicator of access. Here we were looking at time to last dental visit. I've also looked at unmet need, but I'm not reporting that data today. And you're looking at access, and what does predict access? The first level of factors that predict access are individual factors, like we talked about earlier. And they are divided into, predisposing, mostly demographics or biology, however you want to think about it. Other factors such as insurance and income, things that enable you to receive services, and then the level of need, what is oral health status, etc. And then we have the context, the healthcare delivery context in this case, and the other characteristics of the context in which people seek care. And we're breaking up here is this particular area. We're looking at their population demographics and what some of those characteristics that could determine the context of care delivery, but also the dental supply, which we talked about a little bit before. I'm going to show you a little bit more about that. And then getting more into the detail of who are the providers and what are they doing, how are they delivering care, and how does that change access to care. So if you have licensure data, there is very limited amount of information available to you and what you can get out of it. It gives you information about who has a license. Who has a license has something to do, but not everything to do with who's actually practicing. There are dentists into their 80s or older that have lifetime active licenses. They may be, in fact, practicing. As it turns out, for professionals, including dentists, the retirement age is not 65 like we're used to in the general population. There are dentists that could be actually working still, providing direct care, but a lot of older dentists that may actually have moved more into a supervisory role, because you know, for a lot of, you could have 6 hygienists practicing in the office. They need to be supervised by a dentist. The dentist does not have to actually provide services, as far as I understand. They just need to be there to supervise, but not deliver care. So you could have those kind of, you could look at licensure and you wouldn't know who's actually delivering care. And then you have the concept of FTE, where you have the, if I am working, it does not, you have no idea how many hours I'm working, right? So I may be working 2 days a week in total, but that's about half of a full-time person's level of work. In dentistry, at least in California, our data, you know, the dentist work week is commonly 30 hours. It's not the same as what you see in elsewhere. So you can't tell, from licensure data, you can't tell FTE, full-time equivalent practice. You also have a very different style of practice in dentistry. You have clustering to some degree in settings like medicine. A lot of doctors are working in group practices. And that ratio of group to private is actually changing over time, where fewer and fewer are actually in solo private practices. That's not so in dentistry. Dentistry is still dominated by solo dentists in private practices. You have, it's perhaps more common in dentistry, where you have multiple practice locations. 2 days in one office, 2 days in another office, maybe 1 day in another office. And they could be, you know, across zip codes. They could be even broader geographic dispersion. So hard to tell. Retirement age I already talked about, and then productivity, I talked about the number of hours, and also what you choose to do in your practice, how you practice could change your level of productivity. You spend, you know, you might see a lot of patients for preventive services. That's a different style of practice as if I did a lot of root canals in my practice, or I did a lot of implants. The time that it takes to do those services is different. The amount of work that I'm going to actually, the output is different. Okay, so if you were to dive down even further and look at the practice characteristics, these are some of the things that you will see. What's going on in a typical practice? You could look at the dentist demographics, dentist age. Age has a lot to do with how much you work, right? The older you get, you might reduce your office hours. You don't work as many hours. Productivity can actually go down. Gender, this is probably something that's changing. I don't know how rapidly it's changing, but it used to be that a lot of female dentists had fewer hours. They didn't work as full-time. They worked more intermittently. The practice patterns were different. My guess is that a lot of women are in dentistry, and their practice patterns are probably changing. As there's more coming in, they will become more like the male dentists in terms of number of hours they work, etc. Specialization in dentistry is a lot lower than in medicine. A lot lower. Is what we actually wish medicine was, right? So a lot more general practice dentists. The practice structure, the size and the number of employees, you know, you have a lot of solo dentists, and there's, you know, not everybody has a really large practice. You might work with only one dental assistant. When we were doing the survey, there were dentists that really just had one dental assistant, and that's it. Didn't even employ a hygienist. So really small practices, as opposed to some offices where they have 10 chairs, they have multiple dentists in the practice, they have hygienists, et cetera, et cetera. So lots of variation there in terms of what's going on in care delivery. Their financial profile could be quite different. What type of insurance they get indicates what kind of income they might have. Those factors can determine how services are delivered, how much service is delivered, market characteristics, where they are working, where's their office. Are you an inner city dentist as opposed to a suburban dentist, as opposed to a rural dentist? Very different practice as a result of those types of characteristics. Who are the patients? The patients, characteristics of the patients could determine the, what they are asking for, what services they're demanding, what is their level of need, etc. And then work characteristics. We talked a little bit about some of those in terms of the full-time work, etc. So after that long preamble about how different dentistry is, we're going to focus now on the research that we did. So the question that we were trying to address was, so just backing up briefly, we talked about supply. There is quite a bit of research looking at supply, the impact of supply on access. But I thought always it was really inadequate, because until you really understand how that care is provided, you're not going to have a really good perspective in where disparities may come from, and even when you, and also you won't have ability to come up with better solutions of how to address disparities. So that was the goal. Try to see a little bit more what else could be playing a role here that we're not looking at. So we looked at demographic characteristics of the dentist and the relationship to access, their practice characteristics, and we also looked at just the basic measure of supply, which is the dentist to population ratio. We used the FTE dentist to population ratio to sort of try to really take some of that noise away from who's practicing, who's not practicing, and sort of standardize it a little bit. Okay. The data. This is the reason this research got funded. This was supposed to be an innovative way of using data differently than typically it's used. So I started with the CHIS. 2003 CHIS had an unprecedented list of dental questions in it. It was every researcher who's interested in dental care's dream. So there were lots of questions that allowed you to, and also for the entire population, adults, kids. I'm not showing the results for kids today, but we also did the same analysis for children. 2003, a representative statewide survey of California residents. As you know, it's the CHIS has lots of advantages, including the fact that it's got a sufficient sample size in most California counties. It does include the linguistically isolated populations because it's conducted in several languages. Lots of good things about it that made this research possible, because we knew we're not going to lose some of the really important people that we care about. And then, as luck would have it, we had conducted this other survey of California dentists. This was a representative survey of dentists in California in private practice, though. So we did not include dentists that are in corporate practice, such as Western Dental. You probably have heard of that. Those are the sort of bigger corporations that have offices. They're not private practice dentists. But if somebody worked in both, they will be in the survey. So, and we had 3,821 private practice dentists that were generalists. This does not include the specialists. It does not also, the survey did not include some of the dentists that are not providing direct service, such as public health dentists frequently don't, and also the surgeons that didn't provide general care were not included. And then we also try to address the what we couldn't get from these two surveys by adding data from other sources. So we took some data from census because it provided the size of the population, as well as it provided the age, race, poverty level in the individual's area of residence. So what I haven't explained yet is that you have the CHIS data. It's a population level data set, and it has geographic, it allows you to identify population in specific geographic areas. And then we had the dentist survey. Also that one, we had address and all of that information, and we needed to bring these two data together. But the only way we could match these data was at a geographic unit. So we're not looking at what a dentist is doing and then look at their patient population. It would be great if we could do that, but that was not possible. So we're looking at, we merged the two data at a geographic area to be able to look at the impact of the dentist characteristics on the population at that level. So we collected census data to sort of provide some contextual information in addition to what we already had. We tried to address the fact that our survey of dentists was only private practice dentists by going to the OSHPD data to get information on dentists that are working in community clinics. And we also got data from all of the California dental schools that are a source of dental care to a not so insignificant number of the population. And the dental schools provided us with their FTE equivalent number, includes their faculty and includes the students that are providing care. And we try to remove the overlap between the OSHPD data and the dental school data because dental students could practice in clinics. So we try to address as much as we could to try to provide as much information about the providers of dental care as possible. Okay. So we looked at dental visits in the past year, so an annual visit. We looked at, and then we were interested specifically in the characteristics of dentists in the area of residence. And I'm going to explain the concept of MSSA in a little bit more. And then we also had two other variables we created: FTE public dentists in public practice per 5,000, FTE private practice dentists per 5,000. So we could, all of our analysis, we could adjust for those basic supply measures. And so when we're looking at how many dentists in that area are over the age of 60, it's not confused with the fact that the supply, the big elephant in the room, is not accounted for. We ran more models that I care to name, how many there were. We had multiple models. We were only able to add one dentist characteristic at a time to the model. This was a restriction of it was a modeling restriction. So unfortunately, you can't say that I can tell, the age of the dentist in geographic area has is associated with dental care independent of all their other characteristics. We can't do that in this research. And we controlled for all of the individual characteristics that we had access to, and here's the list: age and gender and citizenship, and all of those factors that are important. Just to say that we do not have oral health status in our data, so we try to approximate that using general health status, medical conditions, smoking status. We just try to come as close as we could. Yeah. I think I've dropped it from the list. It doesn't have, no, it does. It does, and it's in there. I just have forgotten to add it in. Thanks for mentioning that. And then we used just one of the contextual variables from the census data, which is the population, the percentage of the population that's white. We didn't have, we could not include the other ones because they were too highly correlated. So we could have added percentage of the population that's low income, and then language and all of those. They were too correlated and we couldn't use them. So we just used one variable. So I mentioned that we merged the data at the MSSA area. MSSA is the Medical Studies Service Area. It's a designation that is used by the office, by OSHPD, and I believe by the Bureau of Primary Care. And it is sort of a rational service area. It looks at the geographic barriers to moving around, or the size of the area, and also the population characteristics. It's a mixture of the two, and it's used to designate professional shortage areas and to designate funds to areas that have shortages, or like the F2HCs often, they can get designation because of if they are designated as shortage area, you can get funds to provide services to these populations because they're determined to be high in need and there's a shortage of providers. We use hierarchical logistic regression models to account for the hierarchical nature of the data and then to account for the variance of the MSSA level variables. Remember, the dentist data comes from a survey, so there's error associated with those estimates, and we figured out a way to deal with that in this kind of modeling. We ran separate models, as I mentioned, for different racial ethnic groups so that we could see the impact on each one. So we're going to move into some of the characteristics of the dentists. Remember, we're looking at these are characteristics averaged over an MSSA, right? So this is not the same as looking at, to say that 25%, well, in this case, it's actually very close. 25% of MSSAs on average have, let's say it backwards, I think. So on average per MSSA, 25% of females are dentists. Okay, but this is the one that, so generalist. As I said, most dentists are generalists. These two, the percentage that are newly licensed and the percentage that are 30 or more years, have had 30 or more years of practice, are kind of important indicators in the world of workforce analysis, because it indicates how many are coming in and how many are leaving, and where they settle is also very important, particularly in rural areas, you know, where you might not have sufficient number of younger dentists settling in, etc. And then this one I particularly wanted to mention. This one shows that about 10% of dentists in the per MSSA are non-white, but if you look at the characteristics of dentists in California, it's actually 60% white, 6% Latino, 31% Asian American, and 3% are other, including African American and American Indian, Native Alaskan. So you really don't have a comparable racial ethnic profile of these providers compared to the population. Really different. A little bit more about the practice characteristics. I mentioned that most of them are solo, but there are also a lot of them are owner employers. It goes along with that concept. About 45% per MSSA hire hygienists. That's quite low. Percentage that work with 2 or more dental assistants, multiple practice locations, how busy or overworked they are in their practice, etc. Average. This one's interesting. Average number of minutes per visit. It's about 45 minutes in the survey. About 52% said they accept discounted fees. We did not ask exactly what that means. Unfortunately, in retrospect, I should have asked, because that could mean anywhere from a 5% or to more. It could mean, well, I let you pay me in installments instead of actually providing a discount. You know, it could be really diverse. We didn't ask, unfortunately. Accepting public insurance. This is something that's actually changed quite a bit since 2009, since dental insurance for adults was cut out of Medi-Cal. And then English, the ability to speak other languages was also something that we looked at. This is the characteristics of the population. Just for information and background, I'm not really going to talk about those in the models, but wanted it to be available here. And now we're moving into the, so the big question that we started with. Do characteristics of dentists make a difference? Are they associated at all with utilization? I'm not providing numbers here because this data is still waiting for publication, but you can get a feel for it. I think numbers are not really that important. What's important here is the direction and the significance and how are they different between different groups. So in terms of we're looking at demographics, we're looking at age and gender. When you're looking at age, you can see that the higher the percentage of dentists over the age of 60 in the MSSA, the lower the percentage of the population that said they had an annual visit. Okay? We're looking at, for Asian Americans, sorry. That's the significant one. You can see the ones that have a star are significant. And the same for Latino populations. But those are not significant for the African American or the white population. And the total population, if you were looking at the role of age, and you were just looking at the total population, you will not see a significant impact. Okay? So differences in terms of age of dentists makes a difference in population's use of services. Second one, looking at gender, female dentists. The higher the percentage of female dentists, the higher the likelihood that the population is reporting having visited dentists. But that seems to be coming primarily from the white population. Why? Different style of practice, maybe? You know, there's a paper out there that you can look at, or looked at the practice profile, or what do female dentists tend to do more in their practice? What kind of services they are more likely to offer? More preventive care. Interesting. It's also, I think, something that's seen in medical practice. Differences in practice patterns by gender. Okay. I've only actually listed the significant results here. So all of the other characteristics that I was showing earlier, if I didn't list them here, is because the results were not significant. And here we have, if dentists have 2 or more dental assistants, if they are busy or overworked, if they have shorter length of appointment, if they accept discounted fees for one or another population group, there are differences. These variables, these characteristics play a different role, or they are associated differently given the specific racial ethnic group you're looking at. Yes. These are all stratified models. Yeah. But the models have the same variables. And these two are the 2 basic supply measures that I mentioned earlier. And you can see that the supply of public safety net dentists tends to have a negative correlation or association with the population, the white population particularly, that are reporting annual visits. This is obviously counterintuitive. Why? If you have more dentists that are providing public safety net, why would one group's access be lower? It's probably got to do with the fact that a lot of the public dentists, these dentists are working in safety net settings, and it might be the difference between who is going to the safety net providers, right? Safety net clinics are located in specific areas also. So it could be that geographic underlying factor. Okay. So going back to where we started from, are there disparities in access to oral health care? Are there racial ethnic disparities in access to oral health care? I thought yes. The data show clearly that different populations, there is a significant association. This is the best that we were able to do at the population level. Characteristics of dentists and how they are organizing their practice and who, their own demographic characteristics tends to make a difference in population's access. Because these practices mean that they are organizing a practice in a way that that has an impact on service delivery. So, for example, established dentists with larger and busier practices often employ young dentists, hygienists, multiple dental assistants, could have multiple locations, may have shorter appointment times or longer wait times. They differ in the acceptance of public insurance and discounted fees. They may have multiple language capacity in their practice. All of those things together means that you're really gearing your practice to deliver care, perhaps, to the populations that are more likely to be lower income, publicly insured, non-white, limited English proficient. Might set your practice in areas that are higher need. So I guess the takeaway point that I'd want to leave everybody with is you really need more refined measures than just these general measures of supply. How many bodies are there on the ground? How many people are there to deliver the service? It's not enough. It doesn't give you enough information to understand how would you go about, if you were interested in addressing disparities, just putting more dentists out there, just training more dentists. You're not going to really change those disparities. It's not sufficient. You need to look a little bit below the surface. You need to, of course, collect more data on the workforce as well. This is 2003 data. There has not been another survey like this. In California, certainly. Nationally, the American Dental Association collects some information, but the sample size that they use is very different. It's quite small. You can't look at it by different geographic areas, and so you really don't know. You can't address some of these issues with those data. One of the ways to do this, of course, is to collect data through licensure. You can collect some useful information. Doesn't have to be a gigantic survey, but each time somebody renews their license, you could add a few important questions in there and get more information about what are dentists doing and how can you use that, how can you change, how can you address disparities. Okay. I think I need to stop talking, but I just wanted to leave you with a couple of interesting stats. We've been following the number of licensed dentists, at least in California. I try to approximate how many are active. It's not great information, but it's not bad. We sort of at least can say who's got an active license. And you look, this one is actually all licensed dentists in the state, and you can see that we're doing a great job at training. So the numbers are going up, but if you look at the percentage that are active, for each one of these years, we have gone from 90% in 2002 to about 74%. A lot of out-migration of dentists apparently in this last round that we're looking at probably had to do with the economic condition, what was going on, but this is important. By the way, California does have one of the largest you know, we have a lot of dentists in the state, a lot. And just last, then you could say, okay, well, dentists, great, we need to train dentists, we need to have sufficient dentists, we need to sort of follow where they are. But there's a big debate going on in the world of dental health care, which is maybe we can train some other providers, particularly hygienists, to do a little bit more than just provide hygiene care. Maybe we can train them to do some fillings, maybe there are certain types of services that they could provide, but that is a big, what's the best way to describe it? It's really hot button. Yes, hornet's nest, hot button issue. There are a lot of people that are significantly vested in this question. So, just wanted to leave you with that. Thank you.
So we have about 5 minutes for questions.
Yes. You're talking about the previous slide on the... In my data, we did have some specialty information, but the size of the specialists that we captured was not, it was about 400 specialists. I don't remember the count of dental practices. We surveyed individual dentists, so, you know, I don't think the data is really well suited to count the number of practices. Another question?
Thanks, Nadia. About the dental care system side, you often created the don't get in surveys. So on the disparities and access side, I don't have a sense of, because you focus more on the system provision side, but the disparities are odds ratios, kind of the characteristics that might lead to some of these disparities.
Right.
But what are the disparities, and what, from your other research, what the rankings that are different
Are you asking what's the level of visit?
Yeah, right, visit. Yeah, the outcomes
I guess what I didn't give you was that. I think I wrote it down somewhere. Yeah. Who's using services by different... Right. Actually, California does have, interestingly enough, a high proportion of the population, at least in CHIS, that report having seen the dentist. And the number, I think I wrote it down if I can find it here, the number of people that say they have seen a dentist surprisingly is high, but there are, I think if I remember correctly, the Latino population utilization was lower than the other groups. But, you know, as you know, so you could see, like, Asian American rate may not be that low, but Asian Americans are diverse population unless you start looking below the surface at the subgroups and what is the utilization, you're not having good perspective on what exactly is going on. I'm going to have to, I don't remember. Yes, go ahead.
Nationally, you're talking about roughly 60% utilization overall with a higher income group, and it's probably all the way down to half of that for the lowest quartile. So, in commercially insured utilization, about twice what it would be for publicly insured, and expenditures, interestingly, are about twice on commercially insured individuals versus publicly insured individuals, even though we know that the publicly insured have higher numbers of underwriters.
So I actually do have the numbers. The percentage of the, no, actually, 67% I have in total had a dental visit in the past year in California. So California is a little bit higher than the national. Yeah, I'm sorry, I didn't bring the breakdown by race ethnicity. Right. like the dentist to population ratio. So you live there. Why?
Well, I think it's because it's correlated to, and I don't know anything about dental insurance, but I know something about the insured rate. I think we have lower uninsured rates in San Francisco because market opportunities.
Sure.
Income effect.
Sure. Sure. Well, the other interesting thing in San Francisco, you have a much larger number of pediatric dentists. They're not, they're all up there. Because I guess it's sort of how the population also thinks about it. If you have children, you want to take them to the dentist, you'll go to a pediatric dentist if you're in Northern California, Southern California. Whether it's because there are not enough pediatric dentists or you just go to general practice. Yes.
Broken down LA by neighborhood.
Uh-huh.
I can't believe you raised that 6.1 of Beverly Hills, West LA. And you took the whole county.
Yes, that's a great point.
80% of
That's a
70%
great
of
point,
county
yeah.
government practices.
Yes. Well, so we know where the dentists are clustered in Los Angeles, right?
I really question whether it was maxed out. I mean, I would just
Well,
question it.
right. Yeah, San Francisco is much smaller.
Mhm.
Right. It's less than 1 million to almost 10 million.
Yes, that's a very good point. That's true. If you break up LA County into different geographic units, we could have very high rates. We will have very high rates in Westwood, Encino, several areas, and we won't have many at all in some others. Yes, Jim.
Is your sample adequate to allow you to sort of break it out by, inner city urban areas, major urban versus suburban versus the rural?
The population sample?
Yeah, profiles by, sort of, what's the picture, vis-a-vis what types of dentists are in those different kind of locations, the density, any of those pictures?
We did. We had a pretty large sample in LA County. So I actually have done a presentation with LA County data specifically, though not necessarily to the, we could probably do it by MSSA. Below that might be too few. Yeah. The adjusted response rate is about 51%. But, the actual response, the raw response rate is lower. It's somewhere around 30%. You have to have a license in every state to practice. Yeah. Yes, ma'am.
So I know you looked at on the provider side, but I was wondering if you controlled for individual mental health status?
No. Mental health status did not exist at the time, I don't think, in the data set. But why mental health?
Because some of the literature that I read, the connection between mental health, so the poor mental health you have, the less likely you are to be diagnosed.
Yes.
Whether or not that plays a role in maybe the provider not feeling comfortable.
Right. Well, there are two, the mental health, obviously, that sort of you may not go to the dentist as often. There's a whole area of special health care needs, individuals that's actually, sometimes it's a physical problem, right? Or disabled populations. Physical problem of going to a dentist that actually can see you, sit you in the chair perhaps, or have a way of providing care to you where you can. I mean, there are individuals in nursing homes. There's lots of populations that have probably very different access profile.
Did you see at the research the difference in terms of the gender of the population? Because my dentist I consulted, he tells me that men are overrepresented.
Yes, we have one of those at home too. Yes. Yeah, so we did control for all of the population characteristics. I put the list up there, but I wasn't reporting any of that information because I was just focusing on what's the role of the dental delivery system on access. But obviously there are lots of individual, in that model that I was showing, the individual characteristics are really the primary determinants of access, right? But we're trying to see the impact of context. So, yes.
One more thing. I believe you said that when you set up the sample, you wouldn't have tapped the corporate.
Yes. We didn't survey the corporate dentists.
Right, because that definitely is a growing segment overall in the country. And oftentimes is geared toward providing services to underserved.
Yes. So they're actually, sort of taking that profile that I was giving at the end of dentists with a lot of, offices at least, with a lot of providers. There are some dentists in private practice that have these large practices, very similar to the corporate practice, and they definitely provide a different, it's very different. I have an analogy, I won't repeat it, but it's just a different type of service, and we did not include them unless an individual self-reported that they also work in private practice. So we captured everybody who works even a small percentage of time in private practice, but it was, the goal of the survey was not, at the time, we were not interested in reaching the corporate practices.
Nadi, thank you very much.
Thank you.